Thank you. So we are going in reverse. No problem. This is also a very important topic of how we are going to manage the diabetic foot, because if we don't take care of the medical side, then we are not going to get the required results. So these are the key points as far as the medical management of diabetic foot is concerned. Of course, antibiotic therapy, the speakers who are going to come, they'll be talking about it, whether it's a broad spectrum or a microbial targeted therapy. So of course, offloading is another thing, proper footwear, both acute and chronic care. The assessment is also very important, neurologic, cardiologic, the hydration, blood volume, electrolytes, and other things. What I will be talking about is the general management. I talk about the glycemic control, nutritional status, anemia, which is very important, pain management, and most important, mood elevation and depression management. So if you talk about metabolic control for patients with diabetic foot, we know that diabetic foot which is infected itself can lead to high glycemic levels. And if there is an infection and the sugars are high, then there is a negative impact of the high sugar on the wound healing. There is an increase in mortality whenever a patient with an infected diabetic foot has got very high sugars. And whenever surgery is done and the infection is removed, of course, the glycemic levels will improve. So we need to monitor the glycemic levels on a regular basis during the ongoing treatment so that we get the best possible results. And as always, because of the predictability and safety, insulin is always preferred, especially whenever there is a infection. So these are the broad management goals whenever we are treating diabetic foot. We want to reduce the hospitalization. Patient should go home quickly. We don't want them to die. We want to prevent obviously severe or hyper or hypoglycemia. We want to manage the fluid and electrolytes so that there is no renal dysfunction, there is no electrolyte imbalance. We don't want very high sugars, because even type 2 people with foot can develop diabetic ketoacidosis. And we like to keep the sugar between 140 and 180 most of the time. Generally, the choice of treatment, what we are using, depends on the severity of infection. So if it's a non-infected ulcer, just offloading is needed, and patient is on oral therapy, we can continue with the oral therapy. But if there is an infection or some other problem is there, or if the sugars are very high, uncontrolled, then obviously insulin is the tool for the management of diabetic foot. Because if there is a diabetic foot infection being treated with oral versus insulin, those who are treated with oral, there was a higher chance of amputation because blood sugars were not controlled adequately. If there is a refractory ulcer which is refusing to heal, if the patient shows fever and other signs of systemic inflammation like high counts, high CRP, or patient's clinical condition worsens, then either we should start the insulin if it has not been started, or if the insulin is going on, we need to optimize the dosage. Once the foot ulcer becomes stable, infection reduces, healing starts, then that means that the strategy is okay. And fully healed ulcer, if the patient was on oral therapy, we can always switch back to oral therapy after the ulcer has healed. In whom to start insulin? Suppose the patient was never taking insulin and he has come to you. If there is a poor overall health, there is metabolic decompensation, they should be put on insulin therapy even if the ulcer is not very severely infected. Any person with limb-threatening vascular or neurologic complication must be started on insulin. Those with moderate or severe infection, including osteomyelitis, immediately you should start insulin. And those with uninfected foot ulcer, mild infection, if there is a very less erythema around the wound, there are no systemic signs like fever or high counts, they can be considered for insulin. It depends on the treating doctor. Those who are already on insulin, some person may be on basal insulin or on premix insulin. If there is a azotemia or there is a raised SGOT or SGPT, then it's an indication to intensify the insulin therapy. Again, if there is a limb-threatening vascular or neurologic insufficiency, we need to intensify the therapy. If there is a moderate to severe infection, we need to intensify the therapy, achieve 140 to 180 target. HbA1c is not important in the acute phase. We need to have a target between 140 to 180. Any person who needs hospitalization because of infection must be switched to intensive therapy. Preferably, maybe you should give an IV drip till the patient is in the ICU. Those who are having uninfected or mildly infected ulcers on oral therapy on OPD basis, they can continue their pre-existing premix or basal or whatever is going on without the need to intensify the therapy. Again, basal bolus in diabetic foot is always a superior thing, because we know that in an inpatient setting we are going to give basal bolus. If we give basal bolus, we know what is basal bolus, then the non-critical patients will improve the glycemic control. There will be fewer hyper and hypoglycemias because we can monitor it very well with the pre-meal and post-meal sugars, and outcome will be good. We know that there is an ease of titration, there is a good glycemic control, lower risk of hypoglycemia. It is flexible, the dosing is simple, and we can use it in everybody. This is not again important as far as the diabetic foot is concerned, but the titration is very important depending on the weight, and so you can increase or decrease the dose depending on the sugars. Now the important thing which we fail to take care of is the nutrition and the anemia. So if the person is having an infected ulcer for a long duration of time, then there is a catabolic state and there is a nutritional deficiency. So malnutrition screening and nutritional support is very important. So if the serum albumin is less than 3.5, if the total lymphocytes are less than 1800, if the pre-albumin is less than 15 or transferrin is less than 150, these are the parameters in your admitted patient to detect that malnutrition is present. Especially low albumin and weight loss, which is recent, if it is not treated, then complications and mortality is going to increase. We should also look at the anemia. Sometimes in infection, the hemoglobin will drop suddenly, and if we don't take care of the hemoglobin, obviously the infection is not going to be treated. And patients who had revascularization surgery, with a graft or whatever, they are at very high risk of intraoperative or postoperative bleeding, and so hemoglobin monitoring and the nutritional state monitoring in general are also very important. These are the ways that you can assess the nutritional status. Anthropometric, you can do a weight, you can do a BMI. Biochemical, you can do a protein, hemoglobin, transferrin. You can look clinically at the wasting, at the muscle weakness, and you can take a dietary assessment. Patients generally, the doctor might have told don't eat protein at all, so they might not be taking any protein. So we need to change that and give them more proteins, because that is needed for the improvement in the muscle mass. This is a very, very important thing, that the person who was mobile suddenly has become immobile. He may be earning member of the family, he's bedridden, and you feel that that there is something wrong with me. So there is a major or minor depression, which definitely influences the physical condition and prognosis, and severe depression can lead to death also. We also know that if there is a above knee amputation, patient lives on an average for 2 years, and if there is a below knee amputation, overall patient may live for around 4 years. That's the average. So the life expectancy is also reduced whenever you amputate the foot. So you need to give treatment for the mood alteration, like antidepressant or anxiolytics. Prescribe it generally, and if needed, you can call a psychiatrist to assess, and you can give the treatment accordingly. And this is generally needed in more than 50% of patients. Pain is very important, and pain, there are so many reasons. I'll just talk about it. Because if pain is there, patient is not able to sleep, patient is not able to spend the day normally, quality of life is poor, psychological, they will worsen. So we need to treat the pain, and generally we use paracetamol or opioids, but I'll talk about that further on. So these are all the reasons that patient can have pain in diabetic foot. You can have increased sensitivity to touch, you can have bone or joint pain, you can have the ulcers which are paining, there may be numbness, there may be tingling, burning, cramps, muscle. There may be myopathy, and there will be muscle weakness. If patient walks, there may be pain. So for every type of thing, the treatment is different. Generally, we should use tricyclic antidepressants like amitriptyline or nortriptyline. We should be using pregabalin or gabapentin, and we should be using something like tramadol. This is very important. As I told you, we look at the outer cycle, but the inner cycle, there is a weakened social relationship, loneliness, isolation, mental anguish, disability, financial burden, shame, stigma. Patients feel ashamed that this has happened, lack of exercise, limited mobility, and this is a vicious cycle of pain, depression, and diabetic foot. And so many studies have shown that if it is not taken care of, then there is going to be a problem. So with that, I'll end this lecture. Thank you so much.